Module 8, Chapter 20. Now we're going to turn our attention to blood pressure, resistance, and blood flow. Blood flow is expressed in terms of flow and perfusion. Flow is the amount of blood flowing through an organ, tissue, or vessel at any given time. Perfusion, however, is the amount of flow per given volume or mass. For example, a large organ might have more blood flow, but have less perfusion. However, a small organ, let's say an ovary, could receive less flow, but actually have more perfusion throughout the organ itself. Now, total flow at rest is equal to your cardiac output, which is why understanding the factors that affect cardiac output, as you learned in Chapter 19, was so crucial. Whatever affects the heart is going to affect your flow. Now, blood flow through individual organs actually will vary depending upon the actual activity of the tissue at any point in time. Hemodynamics consists of the physical properties of blood flow and is based upon pressure and resistance. Blood pressure is the outward force that blood exerts against a vessel's wall. Arterial blood pressure, which you might just refer to as blood pressure, is the outward pressure of blood on the wall of your arteries. Now, the pressure gradient in your systemic arterial system is 100 millimeters of mercury in the aorta to approximately 30 millimeters of mercury in your arterioles. Capillary hydrostatic pressure, which is abbreviated CHP, is the pressure of blood on the walls of your capillaries. Now, capillary hydrostatic pressure begins at 30 millimeters of mercury at the arterial end of the capillary, gradually declines, and at the venial end of the capillary has dropped to approximately 10 millimeters of mercury. Venous pressure is the pressure of blood against the wall of your veins. Now, venous pressure in the smallest venules begins at approximately 10 millimeters of mercury and gradually declines as blood is approaching the heart, reaching about 4.8 millimeters of mercury at the right atrium. Now, let's talk about your arterial blood pressure for a moment. If you look at the screen and look at the section covered in pink, this is depicting where your arteries are. So you'll see the aorta on the left and continuing to the arterioles as you move to the right. And when you look at the arterial pressure, you can see that it fluctuates and that there's a high pressure and a low pressure. The higher pressure is called a systolic pressure, and this is the pressure within the vessels that occurs during ventricular systole. The diastolic pressure is the lower pressure, and this is the pressure in your arteries during ventricular diastole. Remember, during ventricular diastole, blood is not ejected from the heart, but pressure is maintained by the elastic recoil of the elastic arteries. Now, in a clinical setting, you might have to do some calculations with regards to arterial pressure in your patient. The first thing you're going to need to be able to calculate is your pulse pressure. Pulse pressure is calculated by taking your systolic pressure and subtracting your diastolic pressure. Now, you need to calculate pulse pressure in order to calculate what is referred to as mean arterial pressure. Now, have you noticed that as I've been talking about pressure, I've been using one number? Like the arterial blood pressure gradient was 100 millimeters of mercury, and it declines to 30 millimeters of mercury. The 100 millimeters of mercury is the mean arterial pressure in your aorta. And in a clinical setting, mean arterial pressure really gives a better assessment as to the cardiovascular function of your patient. Now, to calculate mean arterial pressure, you need to take your diastolic pressure and add to it the pulse pressure divided by 3. Now, because in your arteries you have this fluctuation in pressure, flow is described as being pulsatile. However, if you look at the capillaries and the veins, there is no fluctuation in pressure. Instead, it's more of a continuous pressure that gradually declines as you move along the length of the vessel. So there is no pulsatile pressure in your capillaries or veins. Now, I wanted to share with you some issues that might occur with regards to arterial pressure and your arteries in general. Arteriosclerosis is an increase in the stiffness of your arteries. This stiffness is created by free radical damage within your arterial wall, and this damage causes the loss of elasticity. So basically, your artery walls become like really old rubber bands. Those rubber bands that are really brittle and break very easily. Atherosclerosis is different. In atherosclerosis, you actually start to accumulate lipid deposits along the inside of your vessel wall, so along the tunica intima. Now, these lipid deposits can calcify like bone, which would make the artery wall stiffer. Also, these deposits can encourage platelet accumulation, which could lead to the development of an inappropriate clot in the area of damage. If this clot or any of the lipid deposit were ever to break free, it would create an embolus, which would flow through the body and potentially lodge in a smaller vessel and lead to a lack of blood flow and tissue death. Also, the deposit itself does reduce blood flow through that vessel, and it's going to make flow harder, so there's also going to be an increase in pressure as well to try to maintain flow. If your patient is suffering from hypertension, hypertension is an abnormally high arterial blood pressure. It's usually clinically diagnosed when your pressure has a systolic pressure over 140 or a diastolic pressure over 90. If your patient has hypotension, you have abnormally low blood pressure. I don't really have any data to support like how low is too low. When I was in Bayfront Regional about 5 years ago now, my pressure when they saw me in the emergency room and had given me too many medications at once and plummeted my pressure was only 70 over 45, and I was still walking around to use the restroom. So, but I am hypotensive normally by clinical standards. So my systolic pressure rarely cracks 100, so my body must be very adapted to functioning at low pressure. Now, let's talk a little bit about peripheral resistance. As I mentioned in the last module, resistance is an opposition to blood flow created by the friction between blood and the tunica intima of your blood vessels. And peripheral resistance is dependent upon many factors. There's blood viscosity, your total vessel length, your vessel radius, and something called turbulence. Let's talk about blood viscosity first. Viscosity is determined by the ratio of red blood cells and plasma proteins to plasma. So basically, it's the ratio of solid to liquid within the blood. Now, if your blood has low viscosity, you have a higher amount of plasma and a lower amount of red blood cells and plasma proteins. So your blood is more watery. In a low viscosity situation, blood flows very easily because you create very little resistance to flow. It's like water flowing through your faucet in the kitchen. And if you have very low resistance, you will have very low blood pressure. Now you could have this low viscosity situation because you have been overhydrated. If you're overhydrated, it increases your plasma volume over what it normally should be. You also could have a low viscosity because you have a decrease in the number of red blood cells or a decrease in the number of your plasma proteins. So you have the right amount of liquid, but you have too little with regards to your solids. High viscosity changes this ratio. In a high viscosity situation, you have more solids than liquids. So this would basically be turning your blood into more of like a honey-like consistency, where there's a lot more resistance to flow because your blood is a lot thicker. It's creating more friction as it's moving through your vessels. And when you have this high viscosity and this high resistance, you're going to need higher blood pressure in order to maintain flow. Now, it's very easy to create a high viscosity situation. You could have an abnormally high number of red blood cells. We had mentioned this possibility of high viscosity when we talked about polycythemia back in our very first chapter. Also, dehydration. Dehydration will lower your plasma volume. So you have the perfect number of red blood cells, perfect amount of plasma proteins, but you have less water. That also is going to increase your viscosity. So when you start trying to think about this low versus high viscosity, imagine water flowing through your tap, how easily it flows with such little pressure as your low viscosity, and then imagine honey in one of your honey bears that you could buy at the store, and that the honey will flow out of the honey bear, but because it is so viscous, you have to squeeze that honey bear really hard in order to get rapid flow out of that honey bear. Next, you have vessel length. And the general rule of thumb is the greater your vessel length, the greater your resistance will be. And that's because if you have more length, you have more contact of blood and the vessel wall. And the more contact you have, the more friction you create, the more resistance you have. And if you have this great vessel length and all of this resistance, your blood pressure is going to have to increase to maintain blood flow along that length. Obesity is a great example of the effects of vessel length increasing on resistance and blood pressure. When you're obese, you actually grow more blood vessels in order to supply that enlarged adipose tissue. Because you have more length, you have more resistance, and the individual becomes hypertensive because of that high pressure that's needed to maintain flow through all of those extra vessels. You then have to factor in your blood vessel radius. Vasoconstriction decreases the size of your lumen. And as we mentioned in our previous module, a small lumen causes more blood volume to physically contact the vessel wall, increasing resistance and increasing pressure. Vasodilation increases the size of your lumen, meaning more blood volume is going to pass through the center of your vessel, meaning less overall contact with your vessel wall, decreasing your resistance and allowing for a decrease in blood pressure. Now, the use of vasoconstriction and vasodilation to regulate resistance and pressure is collectively referred to as your vasoreflexes. Turbulence is any upset in the smooth flow of your blood. Now, turbulence normally occurs in areas of the cardiovascular system where you have really high flow rates, such as blood movement from the atria to the ventricles, blood movement from your ventricles to your vessels, or just within really large vessels with big flow rates like your aorta. This upset will increase your resistance and slow your blood flow. It's also going to lead to an increase in pressure. So how does this all affect blood viscosity? Now you need to remember that systemic blood pressure steadily decreases from your aorta to the venae cavae. Your aorta starts at 100 millimeters of mercury, and as your blood moves through the systemic circuit, it gradually declines until you get to about 4.8 millimeters of mercury in the venae cavae at the right atrium. Now, because of its highest pressure, the aorta has the fastest flow, but this flow rate decreases from the aorta to the capillaries for several reasons. One, you've traveled a further distance, meaning that you're farther from your source of force. You're farther from that left ventricle. Your pressure is less, and that's going to slow you down. Also, your vessel radii are decreasing. As your arteries form off the aorta, extend out into tissue, and branch, you get more vessels, but their radii are decreasing. So it's almost sort of like what happens with vasoconstriction. Those small little radii are increasing your resistance because there's more contact between blood and the vessel wall. Also, just factor in that you have an increase in your total vessel number and an increase in your cross-sectional area. And you just heard that if you increase your blood vessel length, which essentially this is what you're doing, it's going to increase your resistance, which is going to help to decrease your flow. Now, this decrease is really important because you want the slowest rate of flow in your capillaries to ensure that you have the best possible diffusion of materials across the capillary wall. Now, after exchange has occurred, blood velocity increases from the capillaries to the venae cavae, which is weird because blood pressure is actually still decreasing, and blood pressure is that force that helps to propel blood forward. Pressure decreases from 10 millimeters of mercury in those smallest venules to only 4.8 millimeters of mercury in the venae cavae. So if pressure is going down, how is velocity going up? Well, it all comes down to resistance. As you start to return to the heart, you have a large number of venules all merging together, forming fewer veins as you move back to the heart, but these veins have larger radii. And the larger the radius, the lower your resistance to blood flow. So even though pressure is going down, your resistance to blood flow is going down. So you don't have to push as hard in order to maintain a faster rate of flow because you don't have the opposition. Also, you are moving a relatively large volume of blood into fewer vessels as blood moves back to the heart. And that movement of a large volume into fewer channels also helps to increase your velocity. All right, so now let's talk a little bit about mechanisms of venous return, because even though you do have a little bit of pressure in the veins, it is just a little bit of pressure. And in certain areas of the body, you need a little assistance to help maintain that blood flow back to the heart. So you do have a pressure gradient. You have that 10 millimeters of mercury in the venules to the 4.8 millimeters of mercury near the right atrium. So you will have blood wanting to move from the area of high pressure to the area of low pressure. In areas of the body superior to the heart, gravity helps with venous return. The blood in the head and the neck is going to be pulled down towards the heart by the force of gravity. In areas of the body such as the limbs, you have what is referred to as a skeletal muscle pump. Most of your veins are positioned in between skeletal muscles. And when the skeletal muscles contract, they widen and actually can compress the vein in between them. It's sort of like milking a cow, where you would take your hand and you'd squeeze the teats on the cow, which would help to draw milk from the udder and into your pail. By contracting your skeletal muscles, you're essentially doing the same thing. The venous valves are going to prevent backflow as you squeeze the vein, and the squeezing is going to help push the blood forward through the valve that is more superior or proximal. Now, this skeletal muscle pump is very, very important, especially in areas like the lower limbs, which, thanks to gravity, blood flow wants to go towards your feet, not towards the heart. So the best thing that you can do if you are standing or sitting to maintain good venous return in the lower limbs is to fidget. Move your legs around, shuffle. It might annoy the people next to you, but that movement in the limbs is going to contract your muscles and actually improve the return of blood to your heart, which is going to improve your oxygenation and actually keep you more alert. You also have what is called the respiratory pump. When you inhale, the diaphragm, which is the muscle separating your thoracic and abdominopelvic cavities, is going to contract, meaning it's going to go from its relaxed domed shape, and it's going to contract, meaning it's going to move inferiorly and flatten. When the diaphragm moves inferiorly and flattens, it increases the size of the thoracic cavity and decreases the size of the abdominopelvic cavity. Now, these changes in size actually create a pressure gradient. The increase in thoracic cavity size decreases its pressure. The decrease in abdominopelvic cavity size increases its pressure. So your abdomen becomes an area of high pressure, the thoracic cavity becomes an area of low pressure, and blood loves to move from high to low. So this respiratory pump, when you inhale, helps to basically suck blood from the abdominopelvic region up into the venae cavae in the thoracic cavity. Now, when you exhale, your diaphragm relaxes. It goes from its inferior flattened position, and it relaxes and moves superiorly into its dome-shaped position. Now, this is going to reverse your pressure. The abdominopelvic cavity gets bigger and becomes an area of lower pressure. The thoracic cavity gets smaller and becomes an area of higher pressure. Now, technically, blood would want to go from the thoracic cavity to the abdominopelvic cavity, from high to low. However, you have venous valves that are preventing the backflow. So when your thoracic cavity pressure increases and backflow can't occur, the increase in pressure actually pushes the blood in the venae cavae into the right atrium. So it's going to help to get that blood that we have sucked up into the thoracic cavity now into the heart. There is even a slight cardiac suction that occurs during ventricular systole. During ventricular systole, the chordae tendineae pull slightly down on the atrioventricular valves, which slightly increases the size of your atrial cavities. This increase in size creates a slight suction, which does help to pull blood into the atria. Now, let's talk a little bit about how we regulate pressure and flow. There are three main regulatory mechanisms used to help maintain pressure and flow. There's autoregulation, neural control, and endocrine control. Autoregulation describes the ability of a tissue to automatically adjust its blood flow to match its own metabolic demands. And this adjustment involves local vasodilation and vasoconstriction within the tissue. This dilation and constriction is going to exist at the level of the precapillary sphincters. So those sphincters are going to open and close, and it's going to regulate blood flow through your capillaries. Studies have been done to show how autoregulation works. One of the most interesting was actually in the brain when people are listening versus talking. When people are listening, there is greater blood flow to your auditory areas and less blood flow to the motor speech area, which is what's going to regulate speech production. So when you're listening, auditory gets more, your talking areas get less. However, if you ask the person to now speak, you actually have less blood flow going to the listening areas and more blood flow going to motor speech as you are coordinating all the movements involved in speaking. Now, if you have inadequate perfusion within a tissue, you develop hypoxia, which is a tissue oxygen deficiency, and you start to accumulate metabolites such as waste. This hypoxia and these metabolites will cause vasodilation to occur within the tissue, leading to an increase in blood flow. Once you have restored your oxygen and you've removed the metabolites, your vessels will be triggered to automatically reconstrict and reduce blood flow into that tissue. You also have the production of vasoactive chemicals, which are released by things like platelets, endothelial cells, and your perivascular tissues. These vasoactive tissues are released in response to triggers like tissue trauma, inflammation, and exercise. And some examples of these chemicals are things like histamine, bradykinin, and your prostaglandins. Now let's talk a little bit about your neural control. The neural control is going to come through the autonomic nervous system. Now, it's important to note that the vasomotor center in your medulla oblongata only exerts sympathetic control over your blood vessels. There is no connection of the parasympathetic division with the blood vessels of the systemic circuit. Now, one neural control mechanism is the baroreflex. The baroreflex is important for short-term regulation of blood pressure. Now, the baroreflex is going to use baroreceptors that are monitoring stretching in the wall of your blood vessels. Specifically, these baroreceptors are located in your carotid sinuses. So now let's pose the question where what happens if your blood pressure increases over homeostasis? Okay, so blood pressure is too high. That means your goal is to decrease your pressure back to normal. So increase in blood pressure has occurred. We have greater stretching on the walls of our vessels, specifically the carotid sinuses. And this information is going to be sent from the baroreceptors up to your medulla oblongata. In the medulla oblongata, we are going to increase our parasympathetic stimulation. Now, you learned for the first exam that increasing parasympathetic stimulation will decrease your heart rate and it decreases your contractility. You also learned that decreasing contractility decreases your stroke volume. Now, if you combine the decrease in heart rate and the decrease in stroke volume, you end up with a decrease in your cardiac output. Decreasing cardiac output then decreases your blood pressure, which is going to help you get back to homeostasis. At the same time, you're going to have a decrease in your sympathetic stimulation. Losing sympathetic stimulation causes widespread vasodilation. So your arteries are going to start to dilate, which is going to decrease their resistance. Decreasing their resistance will lead to a decrease in blood pressure as well. Now, what if the opposite scenario occurs? What if your blood pressure decreases below homeostasis? Well, if your pressure decreases, you have less stretch on the walls of your vessels, including the carotid sinuses. That means you have decrease in the stimulation of your baroreceptors. That information is going to be sent to the medulla oblongata, and as a result, you will have a decrease in parasympathetic stimulation with an increase in sympathetic stimulation. Now, you learned for the last exam that increasing sympathetic stimulation increases heart rate. It also increases contractility of the heart. Now, if you increase contractility, you increase your stroke volume. If you combine the increase in heart rate and the increase in stroke volume, you end up with an increase in your cardiac output, which will help to increase your blood pressure back to homeostasis. The increased sympathetic stimulation also causes widespread vasoconstriction. So all your little arteries are going to constrict, which is going to increase peripheral resistance, which will also help to increase your blood pressure. Another neural control mechanism are your chemoreceptor reflexes. These are automatic responses to changes in blood chemistry that are detected by your carotid bodies and your aortic bodies. Now, the chemoreceptors in these structures are responding to changes in oxygen level, carbon dioxide level, and pH. So we're going to be responding to changes in our hydrogen ion concentrations within your blood or within your cerebrospinal fluid. Now, these reflexes are triggered by specific chemical changes. For example, hypoxemia is a trigger. Hypoxemia is a blood oxygen deficiency. Acidosis is a trigger, which is an acidic pH. And hypercapnia is a trigger, which is an abnormally high level of carbon dioxide. Now, normally, all three of these do occur at once. Now, when they occur, the effects that are triggered are predictable. When they are triggered, there will be a decrease in your sympathetic stimulation and an increase in your sympathetic stimulation. And as you just heard on the previous slide, increasing sympathetic stimulation causes widespread vasoconstriction, which increases resistance and blood pressure. It also is going to increase heart rate and contractility. The increase in contractility increases your stroke volume, and the combined effect of the increase in heart rate and stroke volume increases your cardiac output and your pressure. However, with this reflex, we also have a respiratory effect. We're going to have an increase in your respiration rate. meaning you're going to be breathing more often per minute. So we're going to be bringing more oxygen into the body than normal and exhaling more carbon dioxide as normal. And if you look at the triggers, this increase in respiration is going to help fix the problems that triggered the response. We're going to gain oxygen, we're going to lose the excess CO2, and when we lose the excess CO2, we actually lose the hydrogen ions, so it rectifies the acidosis. So the cardiovascular effects are going to increase pressure, which is going to increase your blood velocity. So you're going to get more blood flow through the pulmonary circuit, and the change in respiration rate is going to allow us to have a greater rate of gas exchange. The last neural control is called your medullary ischemic reflex. This reflex is going to be an autonomic response to reduced brain perfusion. So we're going to have less perfusion in the brain, meaning less oxygen delivery, and if perfusion is decreased, we have less waste removal. So oxygen levels are going to drop, carbon dioxide and metabolite levels are going to increase. Now, the medulla oblongata does monitor its own blood supply, so it will recognize if it has reduced brain perfusion. The medulla oblongata is also going to get some input from higher brain centers like the hypothalamus. This input is usually in response to exercise, temperature changes, but also emotional stress, anger, arousal, those types of changes. As a result, when this reflex is triggered, there's going to be an increase in sympathetic stimulation, resulting in the effects that you just recently heard with the other two reflexes.